I'm a surgical pathologist. Pathology is the study of the disease. I'm the kind of person, as a patient, you usually don't come into direct contact with unless you try to seek me out. I am the member of the multidisciplinary team who is receiving the tissue when Dr. Livingstone does a biopsy or resects the tumor. I am studying it in the laboratory to make a very precise, accurate diagnosis. So he and his colleagues like Dr. Wilkie and Trent know what to treat. And not just put a name on the disease, we also do our best to provide prognostic information, anticipation of how that tumor is going to potentially behave, so both the patient, the family, and the treating team know how to optimally create the treatment strategy. So I'm going to tell you the story of just sort of from the pathologist's perspective. And generally I get involved when Dr. Livingstone or a clinical colleague indicates to me that they're seeing a new patient. That during the evaluation of the patient, they've identified a mass somewhere in the gastrointestinal tract. And you've seen some of these CT images before, and that's what we're looking at, a cross-section through the body. This irregular dark structure represents the lumen of the stomach. And what's abnormal is that the stomach wall is incredibly thick, and it's thick because there's a tumor there. One way or another. Maybe first a biopsy or going right to a resection, I am given tissue. And it could be the entire stomach, a segment of esophagus or a portion of the liver. And what I'm showing you here is what I see of that stomach under the microscope. I handle that tissue with my hands. We section it. We process it in formalin. And then that is cut in a laboratory so that I am looking at a piece of the tumor that's much thinner than a piece of paper. And it's stained with dye so I can analyze it. And under the microscope, I am looking at different characteristics of these cells to be able to say, is this a gastrointestinal stromal tumor or some other form of a neoplasm that may be treated very differently? Now, I have a lot of experience using the microscope, but occasionally I may require ancillary studies to further confirm my diagnosis. And in this case of this tumor that was removed from the stomach, and you've heard the term and I will try to explain it, I did an ancillary test called immunohistochemistry, trying to show that that tumor that was removed is producing a protein that will allow me to, with 100% degree accuracy, make a diagnosis of a gastrointestinal stromal tumor. And what we're seeing here, indicative of that, is the brown stain that allows me to say that this tumor is producing a certain protein that only gastrointestinal stromal tumors are doing. So I make the diagnosis of gastrointestinal stromal tumor. It doesn't stop there. Based on a variety of important facts, the anatomic location, in this instance the stomach, the overall size of the tumor, how much the tumor cells are replicating or how frequently, I provide a score. And then, based on the integration of all of that information, I then provide you with what I expect this tumor or how this tumor is going to behave. And then subsequent to that, we can analyze the DNA within the tumor to have a greater understanding what kind of mutation, if any, is present, and is that mutation going to be sensitive to some of the current drugs that we have. Now, what I hope to be able to accomplish in this lecture on gastrointestinal stromal tumor is obviously define again what it is. You've heard the perspectives from medical oncologists and surgeon, address the issues of who gets a GIST, why does an individual get one, how is it going to behave, and again, how can we make those kinds of predictions? One needs to look at gastrointestinal stromal tumor in the vast majority of clinically significant cases is that a gastrointestinal stromal tumor unfortunately is a type of cancer. What is cancer? A cancer is a tumor that has the potential to metastasize or spread. And many different kinds of cancers exist. Cancers of the breast, cancers of the lung, cancers of the prostate. And as a pathologist, we subclassify all the different kinds of cancers according to the normal tissues that they mimic. A breast cancer, the cancer cells mimic breast cells, normal breast cells. And when we make this type of subclassification, the normal tissues in the body, most of them are composed of epithelium, like our skin. Those tissues that make up our lung, our breast, those are called carcinomas. We have cancers of cells that make the melanin in our body. Those are melanomas. We have cancers that mimic the immune cells in our body, and those are lymphomas and leukemias. And then we have cancers of cells that form the structural framework of our body, like the metal girders in this building. Those kinds of cancers are called sarcomas. Gastrointestinal stromal tumor is a type of sarcoma. Sarcomas are relatively uncommon, and one of the sort of advantages that we have at University of Miami is that we have a multidisciplinary team that just treats sarcoma. And what does a multidisciplinary team mean? You got somebody like myself who just does pathology of sarcoma, surgeons who mainly just operate on sarcoma, radiologists who really look at the x-rays of sarcoma, and medical oncologists who just treat sarcoma. Looking at the same disease from a different perspective, communicating again, so we can optimally understand what the patient has, how it's going to behave, and treat it. Now, although I just told you the vast majority of gastrointestinal stromal tumors are malignant, should be viewed as cancers, there are a number of examples that are extremely small and may never grow and acquire that potential to metastasize. So in that way, there are some gastrointestinal stromal tumors that are benign, but most of those are usually not clinically significant. And what do I mean clinically significant? They're so small, they're not producing any symptoms. And unless they were detected by mistake or an incidental finding during workup for another problem, probably never would have been diagnosed. You've heard a lot of information already with regards to how uncommon they are. They're very uncommon. But again, an advantage working with a group of physicians specialized in treating sarcoma, we have the advantage of seeing large numbers of these patients, and that helps us expand our experience. But the really simple rule of thumb is, in the vast majority of instances, we don't know why you or a family member developed the gastrointestinal stromal tumor. We have some understanding of the underlying mechanics, what went wrong for it to develop, but we don't know why it occurred. And again, importantly, because when an individual develops cancer, they get very concerned. Do they have a propensity to pass that on to their offspring? With regards to gastrointestinal stromal tumors, again, it's extremely uncommon for it to be an inherited form of the disease. Again, uncommon for gastrointestinal stromal tumors to be hereditary or to be a part of syndromes, but it does occur in a very small percentage of cases. Patients with gastrointestinal stromal tumors have a very broad age range. Vast majority tend to be adults. Why do they occur in adults rather than young children or the elderly? Again, it's a piece of scientific information that we don't know. Why? Dr. Livingstone has presented some of the clinical findings associated with gastrointestinal stromal tumors. Many of the symptoms may depend on the exact anatomic location of the tumors. And those presenting signs and symptoms will lead to an investigation that, like the story that we heard a little while ago, will provide a pathway to identifying the tumor and removing it. We know that gastrointestinal stromal tumors arise along the entire length of the gastrointestinal tract, the majority developing in the stomach. But why do they develop in the stomach? We really don't know why they develop more frequently there than anywhere else. The cells that they mimic, the cells of Cajal, which I'll explain, are located through the entire gastrointestinal tract. More in the small intestine than in the stomach when you think of it in absolute numbers. Why, again, they arise here, we don't have a good understanding. Dr. Livingstone showed some dramatic examples of gastrointestinal stromal tumors with regards to their presentation and complications. Here is the gastrointestinal stromal tumor, this solid tan white hemorrhagic mass. It can arise just beneath the lumen of the gastrointestinal tract. It can be centered in the wall of the bowel or sometimes arise eccentrically on the outside. This example here really producing a protuberant mass that was blocking a portion of the small bowel. This is what happens over time with gastrointestinal stromal tumors that are more aggressive. They continue to grow. They continue to get big. They outgrow their blood supply. They undergo hemorrhage and necrosis, and sometimes a rupture of the tumor can be the heralding event in an unsuspecting patient. This is an example of some of those benign gastrointestinal stromal tumors I was referring to. This is a patient who has a certain kind of syndrome which is prone to produce gastrointestinal stromal tumors. The vast majority of them remain small, never grow, and this is what they can look like, a pea-sized mass within the wall of the small intestine. When I look at a gastrointestinal stromal tumor under the microscope, remember, just like our entire body, they are composed of cells. Billions of cells together forming a mass. And those cells have appearance, just like we do. And those cells under the microscope can be long and cylindrical, as we see here. Or sometimes those cells can be large and round, as we see here. And sometimes some of the gastrointestinal stromal tumors can be composed of an admixture of the cylindrical and round cells. And it's looking at them under the microscope, trying to determine, is this a GIST or is it another type of neoplasm, either aggressive or not aggressive, is really the way I'm spending my time trying to make a precise diagnosis. What are the features I'm looking for with regards that might help me provide information that this tumor is going to behave in an aggressive fashion or less aggressive fashion? I've talked about studies have shown that just what part of the bowel that the tumor arises is very important. The size of the tumor is important, and that's very commonsensical. Generally, the bigger the tumor, potentially the more aggressive it can be. You've heard information with regards to mitotic activity. Mitotic activity really is the reflection of the cell undergoing division. One cell becoming two, four cells becoming 8 until we have billions of cells. And what is the reflection of the mitotic activity? I look at it and I can see how the chromosomes are arranged in that cell, and it indicates that that cell is dividing. And I can count the number of mitoses, and again, scientific studies have shown that there is a correlation of how many mitoses I'm counting at my microscope and how that tumor is potentially going to behave. And I need to do that mitotic count very accurately, because if I underestimate or I overestimate, may have significant ramifications of the kind of information that's being explained to you with regarding the biology of your individual tumor. We're looking at a gastrointestinal stromal tumor. Here are some of the cells that died. Why have they died? They're growing so rapidly, they outgrow their blood supply. Another feature that sometimes that can be associated with aggressive behavior. So, many physicians looking at data from many thousands of patients and doing very sophisticated statistical analyses have been able to develop what is known as a risk assessment, providing information, probabilities, and it's just probabilities of how a tumor, a gastrointestinal stromal tumor, is going to behave. And again, using size cutoffs, using anatomic location, using the number of mitotic figures allows me to calculate or use this reference scientific data to indicate what are the likelihoods this tumor is going to behave aggressive or not. And again, that can influence how the tumor is going to be treated. That's all being done at the microscope. Dr. Livingstone, Dr. Wilkie, and Dr. Trent want me to be 100% accurate when I make a diagnosis. And although I feel very confident when I'm looking at a routine section of the tumor under the microscope, I indicated that there are ancillary testing that could be done to help me further confirm my diagnosis. And that is known as immunohistochemistry. And what is immunohistochemistry? It's really a name that reflects that we are now able to develop markers specific for a molecule, c-KIT. c-KIT is like my arm. It's a protein sticking out of the cell into the environment. We have in our laboratory a marker that accurately identifies when c-KIT is present. And so by taking advantage of the presence of those markers and putting a visual tag on that marker, when that marker is binding that gastrointestinal stromal cell, I can see it under the microscope and it can confirm my light microscopic diagnosis. And again, this is what it looks like in real time. This brown staining meaning the marker is a brown marker and that there are millions of molecules of c-KIT that are being expressed by these cells that allows me to be able to visualize that. That's how I make diagnosis of a gastrointestinal stromal tumor. So let's take a step back with regards to gastrointestinal stromal tumor. That term, relatively recent, really first devised in the early 1980s. And so when a cell of Cajal gets a message from a nerve you got to contract, it's stimulating many smooth muscle cells in the bowel to contract, so it contracts in a coordinated fashion. So these cancers are mimicking this cell, which is an intermediary cell between the central nervous system and the muscle cells of the gastrointestinal tract, causing them to move the food through our gastrointestinal tract. We're looking here at a normal wall of the gastrointestinal tract. These cells are the muscle cells. These cells in here, highlighted by c-KIT, you can see all of the delicate processes extending out. So one cell may come in contact with 1,000 smooth muscle cells, again, allowing the bowel to function normally. That's the normal cell that these cancers are trying to mimic. And one of the important molecules that allows the cell of Cajal to be born, to differentiate, and to function is that protein known as c-KIT. And that protein, again, if I am a cell, is located extending out from the surface, and a component of it is extending into the body of the cell. And the name or the function of this is that the scientific name is a tyrosine kinase. What does that mean? It's sort of very simplified. It is a molecule that makes things happen. And once it is stimulated, it sets off a whole cascade of events within the cell. And it's a very complicated molecule that is sitting on the surface of the cell. Complicated, very important basic biological functions, as I already alluded to. Allows it to be born, to differentiate, plays very important roles in survival of the cell, producing cell divisions, differentiating along its normal line and performing its function. So what happens in patients with a gastrointestinal stromal tumor? They develop a mutation in the DNA of maybe one of the cells of their interstitial cells of Cajal, statistically more likely in their stomach than anywhere else. Here we're looking at, remember, you have millions and millions of different genes within your body. This is what this reflects. Patients with a gastrointestinal stromal tumor develop one mutation in their gene, and what that mutation results in producing a c-KIT molecule that is no longer normal. It's abnormal. It has advantages in comparison to its neighboring normal cells of Cajal. I can proliferate faster. I grow. I get big. I can metastasize. And that's what this initial event results in. And again, a big question is, why did that initial event ever happen? We don't know. If we knew why it would happen, maybe we could form a way to prevent it from happening. So that's one type of mutation, a mutation in a gene for c-KIT. And that accounts for the majority of mutations that lead to the development of a gastrointestinal stromal sarcoma. But it's very important to be aware that as scientific investigations have occurred, we're identifying additional mutations that can also produce the same type of tumor. And understanding, again, which mutation is present may have a very important impact on what type of therapy, particularly what type of medical therapy is appropriate for the tumor you or your family member may have. And again, I want to highlight, this is normal. A normal cell, you can view me as a normal cell. c-KIT, multiple molecules on my surface. When it's binding the message it's looking for, the molecules of c-KIT, two of them come together. Once they come together, with, say, a cantaloupe, representing that's the signal they're looking for, they become activated. What happens when there is a mutation in c-KIT, they come together without needing the cantaloupe. And as Dr. Livingstone indicated, once that happens, the cells are always active. always producing things, always undergoing cell division, taking control of the very complicated processes that exist in every single cell. It takes over the cell. And we've heard from Dr. Wilkie, those mutations may affect different portions of my c-KIT. It could affect the wrist, it could affect my elbow, or it could affect that portion that is inside the cell. With each mutation may be associated with the different amounts of sensitivity to drugs like Gleevec, or maybe that mutation makes the cell completely resistant to Gleevec. Large scientific studies have looked at those patients with GIST with different kinds or locations of the mutations and be able to say this mutation has the potential to behave in sort of this degree of aggressive behavior. And again, so molecular information is extremely important with regards to whether the tumor is going to be sensitive to drugs and what, in a statistical basis, can one expect how the tumor is going to behave. What is sort of the evolution of a gastrointestinal stromal tumor once it develops? Starts off with that first mutation in c-KIT, I become a GIST. Then what happens to me? What about if I can't be removed? Well, I am always trying to evolve. I see a drug, Gleevec, yeah, it kills a lot of me, but not all of me. And I'm going to try to make it so I'm no longer resistant. And so what happens is there are additional mutations occur in these tumors that make them insensitive to Gleevec. What's the hope in the future? That we can identify exactly what, and we have a good idea what many of them are, but very importantly, identify new forms of therapy that, just like Gleevec worked on c-KIT, new forms of therapy that work on these additional mutations to silence them and to be able to cure the patient. What does it just look like when it's successfully treated with Gleevec? Well, if you keep in mind that reference of the second or third slide I showed you where the GIST was composed of many of the cylindrical cells, we're looking at the stomach in which has been successfully treated, or this is the stomach, this is the GIST, and it's so pale because most of the tumor cells are now dead. What is present in the place where the tumor cells once were? It's a scar. And so sometimes a big GIST that may be successfully treated may reduce in size, but may never completely disappear because they're scar tissue as a remnant of where it once was. You've heard a lot of information with regards to, what is the outcome, and again, it depends on a variety of different biological factors. When you group large populations of patients with GIST, again, together, it's a significant disease, obviously. There's a significant risk of developing complications, of spreading elsewhere, and the common locations of where it's going to spread are other sites within the abdominal cavity, the surfaces of the abdominal cavity, sometimes within the liver, and infrequently other forms of viscera. Important aspects of GIST. It's the most common mesenchymal tumor malignancy of the bowel. We have a very good idea now of being able to predict statistically how it's going to behave. And now we've gotten much smarter over the last several decades in that we've been able to identify the different mutations that are associated with both the genesis of gastrointestinal stromal tumors and their potential sensitivity to drugs. How did we get all this information? It really took a lot of time, effort of very both smart and creative doctors, scientists, and it also takes money to allow people to spend their time studying how do we cure that mutation or how do we treat that mutation. And it really is a community of people from many different backgrounds and expertise working together in the end to develop a treatment strategy that hopefully is going to be curative. So I'll stop there. Any quick questions? Or Sarah, do you want me to?
Well, we're going to have a Q&A panel now, which is a great opportunity to start the questions. So thank you very much, Dr.